Welcome to this Step 2 clinical knowledge review on Pediatric Emergencies test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for Pediatric Emergencies and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the pediatrics and emergency medicine sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for pediatric emergencies. Second, we will apply specific strategies for questions about epiglottitis versus croup, status asthmaticus, diabetic ketoacidosis in children, and acute abdominal emergencies. And third, we will master the next best step question format for diagnosing and managing these critical pediatric conditions. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the epiglottitis versus croup split. When you see a question about a pediatric patient with upper airway obstruction, immediately ask yourself, is this epiglottitis or is this croup? For epiglottitis, look for the toxic-appearing child with a high fever, drooling, and tripod positioning. The child will have a muffled or hot potato voice, and the classic X-ray finding is the thumbprint sign on a lateral neck film. This is an airway emergency, and the boards want you to know never to examine the throat because it can trigger complete obstruction. For croup, look for the barking seal-like cough with inspiratory stridor, typically in a younger child between 6 months and 3 years. Symptoms are worse at night, and the X-ray shows a steeple sign. Croup is usually viral and responds well to a single dose of dexamethasone with nebulized racemic epinephrine for severe cases. The boards absolutely love comparing these two, so this should be your first mental framework. Our second strategy focuses on recognizing status asthmaticus, which the boards test frequently. Status asthmaticus is a severe asthma exacerbation that does not respond to initial bronchodilator therapy. When you see a question stem describing a child with known asthma who is wheezing, tachypneic, and using accessory muscles despite initial albuterol treatments, you should recognize this as refractory status asthmaticus. The boards want you to escalate to continuous nebulized albuterol and systemic corticosteroids, typically intravenous methylprednisolone. The key danger sign is a silent chest, which means air movement is so severely reduced that you can no longer hear wheezing. Other red flags include altered mental status, inability to speak in full sentences, and a normal or rising carbon dioxide on blood gas, which indicates the child is tiring out and may need intubation. If the question describes these ominous signs, think about intravenous magnesium sulfate or emergent intubation. Now let us go through high-yield stem recognition. For epiglottitis versus croup, the classic distinction is a child with acute stridor and respiratory distress. You need to determine the age of the child, the presence or absence of drooling, the severity of the fever, the X-ray findings of thumbprint sign versus steeple sign, and whether the child looks toxic or non-toxic. For status asthmaticus, look for a child with known asthma who is not improving after multiple albuterol treatments. The stem will emphasize refractory wheezing, accessory muscle use, a silent chest, or a rising carbon dioxide on blood gas. The answer is usually escalation of therapy. For pediatric diabetic ketoacidosis, the classic presentation includes polyuria, polydipsia, weight loss, vomiting, abdominal pain, fruity breath, and small respirations with hyperglycemia, anion gap metabolic acidosis, and ketonemia. These stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A 12-year-old girl with no significant past medical history presents with a 3-day history of increased thirst, frequent urination, and vomiting. Today, she became lethargic. On exam, she has dry mucous membranes, deep rapid breathing, and her breath has a fruity odor. Her blood glucose is 540 milligrams per deciliter. What is the most appropriate initial step in management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. A young girl with polyuria, polydipsia, vomiting, lethargy, fruity breath, small respirations, and a markedly elevated blood glucose. This is a classic new-onset diabetic ketoacidosis presentation. Step 2. Apply the rule. The board rule you must memorize is that the first step in managing pediatric diabetic ketoacidosis is always aggressive intravenous fluid resuscitation with normal saline. You must correct dehydration before starting an insulin drip. Step 3. Eliminate wrong answers. Subcutaneous insulin is needed eventually, but is never the first step because giving insulin before fluids can worsen hypovolemia and cause dangerous electrolyte shifts. Oral rehydration is inadequate because the child is lethargic and vomiting. Intravenous sodium bicarbonate is rarely indicated in pediatric diabetic ketoacidosis and can actually increase the risk of cerebral edema, which is the most feared complication. The correct answer is B, intravenous normal saline bolus. Here is our second practice question. A 4-year-old boy is brought to the emergency department with a 6-hour history of high fever, sore throat, and difficulty swallowing. He is sitting upright, leaning forward with his chin extended. He is drooling and has a muffled voice. His temperature is 39.5 degrees Celsius. What is the most appropriate next step in management? Think through this one carefully. The key features here are the toxic appearance, drooling, and tripod positioning. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This describes a classic epiglottitis presentation in a 4-year-old. High fever, drooling, tripod positioning, and a muffled voice. This is an airway emergency. Direct laryngoscopy in the emergency department is dangerous because manipulating the airway in an uncontrolled setting can trigger complete obstruction. Nebulized racemic epinephrine is the treatment for croup, not epiglottitis. A lateral neck X-ray showing the thumbprint sign may help confirm the diagnosis, but imaging should never delay definitive airway management when the child appears this sick. The correct answer is C. Secure the airway in the operating room because that is the controlled environment where the airway can be safely managed by anesthesiology and otolaryngology. Now let us review diabetic ketoacidosis management for the boards, because this comes up constantly. The most critical step is initial fluid resuscitation. Begin with an intravenous normal saline bolus of 10 to 20 milliliters per kilogram over the first 1 to 2 hours. The boards consistently emphasize that fluids must come before insulin. After the initial bolus, transition to maintenance fluids and closely monitor glucose every hour and electrolytes every 2 to 4 hours. For insulin, start a continuous low-dose intravenous insulin infusion after the fluid bolus. Never give an insulin bolus to pediatric patients. When the blood glucose falls below 250 to 300 milligrams per deciliter, add dextrose to the intravenous fluids rather than stopping insulin because you still need to close the anion gap. The most feared complication in pediatric diabetic ketoacidosis is cerebral edema, which can present with headache, altered mental status, and bradycardia during treatment. Treat cerebral edema emergently with intravenous mannitol or hypertonic saline. Here is our third practice question. An 18-month-old boy presents with intermittent episodes of severe crying and drawing up his legs toward his abdomen. Between episodes, he appears calm. His parents report a dark red, jelly-like stool. On exam, a sausage-shaped mass is felt in the right upper quadrant. What is the most appropriate initial step in management? This is a classic pediatric abdominal emergency. Think about the age of the patient and the key physical findings before we walk through the answer. Let us break down this answer. The classic pattern here is the triad of intussusception. Intermittent colicky abdominal pain with legs drawn up, current jelly stool, and a sausage-shaped mass in the right upper quadrant. When you see this triad on the exam, the diagnosis is intussusception. Now the key distinction, an air contrast enema, is both diagnostic and therapeutic. It confirms the diagnosis and can successfully reduce the intussusception in the majority of cases. Emergent surgical consultation is only needed if there are signs of perforation, peritonitis, or if the enema reduction fails. A computed tomography scan is not the first-line test for a classic presentation. An upper gastrointestinal series with small bowel follow-through is for suspected malrotation with volvulus, not intussusception. The correct answer is B, air contrast enema. Here is a critical test-taking pearl about the pediatric acute abdomen by age. The boards love testing age-based associations for abdominal emergencies. In neonates and infants, think necrotizing enterocolitis, malrotation with volvulus, pyloric stenosis, and incarcerated hernias. In toddlers between 6 months and 3 years, intussusception is the classic diagnosis. In school-age children and adolescents, think appendicitis, testicular torsion, and ovarian torsion. Always match the age of the patient to the most likely diagnosis. A few critical rules to memorize. Bilious vomiting in a neonate is malrotation with volvulus until proven otherwise and requires an emergent upper gastrointestinal series. An olive-shaped mass with projectile non-bilious vomiting in a 3 to 6 week old infant is pyloric stenosis, confirmed with ultrasound. The exam tests these age-based patterns very frequently, so commit them to memory. That wraps up our review of Pediatric Emergencies test-taking strategies for Step 2 clinical knowledge. Remember to review the Pediatrics and Emergency Medicine chapters in First Aid and your question bank. Focus on the diagnosis and management frameworks we covered today for epiglottitis, croup, status asthmaticus, diabetic ketoacidosis, and acute abdominal emergencies. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.